To kick-start, I'm going to introduce Susie Piper, who is a general paediatrician. She works in a place that I can't pronounce, just south of Sydney. She has an interest in ambulatory care, and she describes herself as one of those crazy dog people, which I'm going to let you explain a little bit more yourself, I think. Okay, but anyway, over to Susie, so thank you.
Thanks, Danny. So I'm a general paediatrician in a place called Wollongong, or if you're an Aussie and you live in the Gong, we call it the Gong, which is a big, beautiful coastal city about just over an hour south of Sydney. So we're a level 4 paediatric unit, which means we've got a 24-bed children's ward. We have a neonatal unit with 12 beds, although we often have 14 or 15 babies. But it means as a general paediatrician on call in Wollongong, you'll be called about everything from neonates to children in emergency. You'll also be called by another hospital sort of about half an hour south of us that has an emergency department but no children's ward, so we get transfers from there as well. So the papers that I've chosen to talk about today, just waiting for my slides to come up, are a mix of papers, some of them relevant to acute paediatrics, some of them more relevant to general paediatrics on the ward. And the first one I want to talk about, Stuart's talked about it a little bit this morning, is about probiotics. Now, why are probiotics important? Probiotics are really big business. So if you go into your local pharmacy, there's a wall of product with various different recommendations. And if you do a quick Google search on benefits of probiotics, it's amazing the claims that are out there about melting belly fat, preventing Alzheimer's, lots and lots of stuff about improving your gut health, boosting the immune system, improving your heart health. There's all sorts of claims out there. And certainly one of the very common claims and recommendations is about being helpful when you have diarrhoea. And I think that recommendation has also made it into some gastroenteritis guidelines. So I'm talking about the two papers that were published in the New England Journal of Medicine. And there's two studies. So there's the one that Stuart mentioned this morning that was done in Canada, and there's another one done in America. And they're both published in the same edition of the New England Journal, which was November last year. And there's an editorial as well. And the studies are similar enough that I think we can consider them together. The main difference between them was the American group, which was 10 emergency departments with the Pecan research group. They just used one probiotic, the Lactobacillus rhamnosus, whereas the Canadian group used that one plus another organism. And you see, they got nearly 2,000 infants, and they were talking about children 3 months to 4 years of age presenting to the emergency department with acute gastro, and the children were randomised to a 5-day course of either probiotic or placebo. I think both studies had very robust methodology with the probiotics looking and tasting the same, and really quite stringent follow-up where they received a follow-up phone call every day for 5 days and then another call at 14 days after the acute illness. And this is what they found. As we've heard this morning, neither trial showed any difference with the probiotics, particularly with duration of illness, missed childcare, unplanned hospital visits or things like that. And there were similar rates of adverse events between the two groups. So really the conclusion from that is that there's really no role for probiotics in children with acute gastroenteritis. And you can see a Twitter poll from, I think it was done around the time the papers were released, and the majority of us are saying, I think there's 94 votes on that, so it's only a small random Twitter poll, but the majority of us are saying, no, we wouldn't recommend. I don't want to throw the baby out with the bathwater and say probiotics are bad and useless. There is a role and benefit for probiotics in certain situations, and certainly the main one with diarrhoea is antibiotic-associated diarrhoea. There is evidence for that, and there is also evidence in the premature neonates with risk of sepsis and enterocolitis. But certainly when the chemist and people are saying to parents you need to take probiotics when your child's got gastro, it's okay to tell them, no, you don't need to. So the next paper I want to talk about is a controversial one, which again, there's been quite a lot of discussion about it on social media and in the FOMED community. And it's about acetaminophen, or I much prefer calling it paracetamol, for febrile convulsion, preventing recurrence of a febrile convulsion. It's a study that was done in Japan, single centre. It was prospective, open randomised trial where the children were randomised to either receive a 6th-hourly dose of 10 milligrams per kilo of rectal paracetamol or no treatment. So there was no placebo. So the treatment group got paracetamol 6th-hourly for 24 hours. The other group got no treatment. In fact, the parents were told not to give any antipyretic. Now, what they showed, they recruited over 400 patients, over 400 patients were randomised, but you can see there's actually a large number of patients who were excluded. And the reason they were excluded was because they'd been given a diazepam suppository, which again I think is certainly not common practice or standard practice where I work, but I presume must be something they do in Japan when kids come in with a febrile convulsion. And they did show that the children who received acetaminophen had a significantly lower number of recurrent febrile seizures, and that effect was most marked in the age group sort of between the 2 and 5-year-olds, where you can see it was 4.1% versus 22.6%, so pretty significant. And you think, okay, so should we all change what we've been doing, which for many, many years I've often said to parents that giving regular paracetamol or regular ibuprofen won't prevent your child from having another febrile convulsion. Fever is not in and of itself a bad thing. It's a sign of the immune system doing its job. And I know there's people who believe we shouldn't treat fever, that we're stopping the immune system from doing its job. I'm not in that camp because I know how sick I feel when I get a fever. And so I believe in treating fever to make them feel better and for comfort, not because I'm trying to prevent them from having another febrile seizure. But I guess this study does make us ask the question, but I feel as though it hasn't been answered yet and that we perhaps need to go back and revisit this, is should we be giving regular antipyretic and would we reduce convulsions? But the other concern, so the two concerns I've got with this study is the recurrence rate seems really high to me. I'm sure I would see lots more recurrent febrile convulsions if between 20 and 25% of kids who have one have another one in the same illness, and I'd feel as though I don't see that very often. And the second bigger issue for me is the ethical issue of, is it ethical to withhold antipyretic from kids for 24 hours? I know how sick I feel, and I'm concerned that no, it's not a great thing to do. And again, another Twitter poll, just over 100 votes at the time that the study was published, and most of us are saying we would treat for comfort in terms of giving regular paracetamol. So now I want to move away from acute paediatrics to neonates, so relevant to those of us working in general paediatric units with special care nurseries. So I'm not talking about a NICU where you're looking after your 23, 24 tiny little prems. This is our special care nursery where we're looking at babies sort of 32 weeks and above. And this is a study that was published in mid-May called the Hunter trial. And we've been talking about research this morning, and this is a study that we got to participate in at our hospital, so not a tertiary centre. This is a study that was done at 9 multi-centres, so 9 centres across Australia, each of them with a reasonable sized special care nursery, delivering at least 2,000 babies a year. And you can see the group they were looking at is 31 weeks and above and 1.2 kilos and above. So this is not the little tiny ones. This question about CPAP versus high flow was studied in the tiny ones in the Hipster trial. This was kind of asking the question in the older age group, and it was a non-inferiority trial. So they were looking at is high flow as good as CPAP for managing respiratory distress in that group of babies? So they recruited 754 infants, and you can see the mean gestational age and birth weight there. And what they showed is that high flow is not as good as CPAP, so CPAP is better. High flow had a higher incidence of treatment failure. Now, these were all nurseries that were good at CPAP, used to doing CPAP, and when a baby had been randomised to high flow but needed escalation of treatment, the baby was then put on CPAP. But the other really relevant findings with this study was that there wasn't any significant difference in the kids who needed mechanical ventilation or transfer out to a higher level or adverse events. And so one of the take-homes for me about this particular study is if your nursery is able to do CPAP, then continue to do it. CPAP's good and we can manage a lot of babies with respiratory distress. But if you're a lower level or a smaller nursery that doesn't have CPAP capacity, and so if you've got a baby that has respiratory distress and is going to need support, you're going to have to transfer that baby out. High flow is actually a really good option for those nurseries, and I think this study shows that 80% of the time you'll get away with high flow and not need to transfer the baby out. And most units are doing high flow in their children's wards, and it's not a big stretch to do high flow in the special care nursery. And we all know the sort of technology and equipment is a little simpler in that group. Okay, I don't think that I can talk about top 5 papers in general paediatrics in the last year without at least mentioning the infamous Lego paper. I'm not going to spend a lot of time on it. Grace Leo has summarised the paper very nicely in this infographic. I think they're a little cheeky describing it as an international multi-centre trial. That is how it's described in the paper. Where we all know it was 6 paediatric clinicians swallowed a Lego head and then searched through their poo until they found the Lego head. Notable things about this paper was the development of the fart and shat scores. But the important thing was this paper really obviously touched a chord and was very quickly, went viral, was picked up by mainstream media, had people being interviewed on the BBC, in Canada, in America. James Corden, the Late Late Show. Now, when I arrived here on Sunday night, they were setting up a film shoot out the front for the Late Late Show, and I thought, oh, maybe they've heard that Don't Forget the Bubbles crew are here. On a sort of semi-serious note, so I think great things about this paper was the sense of humour involved, and I think that is how it needs to be read. But those who got interviewed on the media did take advantage of the opportunity to point out swallowing a Lego head's okay, but swallowing a button battery, for example. So there was a bit of a public education opportunity. And I think I also need to mention the follow-up letter to the editor, published in the Journal of Paediatrics Child Health, where a European group have proposed the POOP study as a follow-up, with a diagram you can see here where they've introduced a placebo and a crossover. The last paper, it's actually 2 papers that I want to talk about, total change of pace, is to talk about rudeness. Again, there's a paper published in 2015 that I think probably lots of people are familiar with. It was discussed in social media. A study done in Israel with neonatal teams, a simulation-based study, where there were 24 teams of doctors and nurses from various neonatal units in Israel. And they would work their way through a simulated scenario involving a premature infant with necrotising enterocolitis who was deteriorating and eventually developed cardiac tamponade related to a central line. And the teams were randomised to be exposed to rudeness or neutral comments, and then blinded assessors would look at the video of the simulation and mark the performance and the diagnostic scores and things of the teams. And not surprisingly, what they found was that the teams that were exposed to rudeness did not perform as well as those that had neutral comments. The rudeness they were exposed to was not, these doctors are hopeless. It wasn't talking about individual performance or performance of the teams. It was fairly mild. It was a foreign expert who was here to observe the simulations, and at 2 different points during the simulation, the expert would make a comment. One was about the healthcare system in Israel in general, and I hope I don't get sick while I'm here because I don't have great confidence in the healthcare system here. And the other was about staff in the units that they've seen here wouldn't last a week in their unit back where they were from. I think we've all experienced when you are involved with resuscitation or looking after someone critically unwell or something's going wrong at work. I think we've all often encountered people who get shouty or cranky or rude in their communication, and our impression is it doesn't help, and it adds to everyone's stress. And I think this paper and this next one, I guess, provide some evidence to back that up, that rudeness doesn't help. Rudeness affects your medical performance, and in fact, it will flow through and affect patient safety. So this one is hot off the press, just published on the 31st of May in BMJ Quality and Safety, and it's a similar simulation-based study. This time was looking at anaesthetic trainees who were randomised to, they were doing a simulated operative scenario where a patient deteriorates, I think with occult hemorrhage, and half the time the surgeon would be rude or, and again, as far as I can tell from the paper, it wasn't you loser type rudeness, it was the surgeon was clearly impatient and cranky versus neutral. And blinded assessors watched the video and graded the performance, so the assessors didn't know whether the trainee was exposed to rudeness or not. And you can see that the people exposed to rudeness did not perform as well on the scenario as those who weren't. A comment on the paper is that the trainees were also asked to self-report their performance, and they said they didn't have a difference, which perhaps means self-reported scores are not that useful. But the trainees who were exposed to rudeness did comment that they felt that the rudeness did affect their performance. So I feel as though there's a strong message for all of us there, is that rudeness or incivility at work is really unhelpful, and we need to be conscious of our own behaviour. And I think we don't know, sometimes we don't know until we're in a resus or an emergency situation how we respond and react. So we need to be mindful, and if we can feel our communication deteriorating, it's a bit like we were hearing yesterday, stop, take that 10 seconds, take a breath, recenter, work on yourself before you start working on the team. Pardon me. Sorry. I think it's really important that we call out, we make sure that we're not rude ourselves, and that we call out rude behaviour when we're seeing it, and that we're conscious of that's really unhelpful and it's going to affect our performance. And that's where I'm going to finish. Thank you.
Thank you so much, Susie. That was really, really inspiring. There are no questions just yet on Twitter. Are there any questions in the audience for us to start? Yes. Is there a roving mic? Tell you what, why don't I do that? Thanks, Ian.
Hello there. Thank you very much. I'm really struck by how significant that difference in performance was when exposed to rudeness and a critical eye. I wonder if that is also translatable to our exams and how examiners behave during exam stations. They're often told to be quite dispassionate. They're often told not to smile, not to interact with us in any way that may give us human cues. And that could be a form of rudeness. And are we potentially underperforming because of the way that we're tested?
I think it's a really fascinating comment, because certainly I examine for the college in Australia, and we are very, clearly instructed. They work, I think, really hard to calibrate us and to try and even the playing field as much as possible. But part of that evening is to say, be neutral in your responses and your behaviour. And it's interesting, I find it quite difficult, because I'm one of those, I will give encouraging cues, and I almost feel like the college is telling me, tone it down and be careful. But I think it's a really good point.
Thank you. Any other hands up in the audience? There's one at the back, Ian.
It's more a comment, really. I've discussed this before with colleagues, and I think incivility actually loses EM trainees as well. They spend their whole lives making work for other specialties and get backlash for perfectly reasonable referrals, and then we lose them to specialties which are kinder to them.
There is something that's come through on Twitter. Sorry, about civility matters, which I'll let Richard reference very quickly.
Yeah, there's been quite a few people who've referenced the @CivilitySaves hashtag. So this is Civility Saves Lives campaign looking at exactly that. And I think more and more specialities are becoming aware of the fact that it does impact on performance. There's also another tweet that's cross-linked us to one of the other concurrent sessions that's going on, Mike Farquhar talking about sleep and the importance of being well rested and how that affects your mood and how you go on. So something else to consider there.
Sure. Loads of questions coming. Okay.
Thank you for your presentation. I think we all agree that civility matters. I wondered if you had any thoughts about how to challenge rudeness when you see it, because I can certainly admit myself that there's occasions where I've seen it and perhaps could have done more.
I think it's really hard, especially with our hierarchical system, particularly for trainees who are beholden on us as their supervisors to sign off their training. It's very, very hard in that context to speak up. But I feel as though if we work on the culture of our departments, and it's cross-disciplinary, it's not just medical, but that it's just an expectation that there won't be rudeness and that incivility will be called out. And I guess for us as leaders, modelling that good behaviour. And it flows through to, and I'm as guilty of this as anyone. I was called out recently about one of my sayings is, baby checks, the bane of my life. You know, there's no such thing as an urgent baby check because you'll be rung saying, we're bed blocked, we need baby checks. And I'm guilty of calling out the madwives, you know, like moaning about the midwives. And then I realise it's actually really bad when I do that because I'm modelling that behaviour. And just like that cartoon, my trainees then go and model that behaviour to the juniors. So it was a wake-up call for me when I was called out on that. That cartoon, by the way, I did get permission to use it. It's by someone, I think Ian Kelleher, who's an anaesthetic trainee in Dublin. And I emailed him saying, can I use your cartoon? I just found it by Googling and he was happy for me to use it. And so I'm sure he'll be happy for it to be tweeted.
Thank you. We've got another question over here. No, there's one more over here then. And then just while you're moving over, there's been some fantastic stuff from Bristol about the way they look after all of their team and the welcome they give to their new doctors and nurses and allied health professionals who are coming into the department, and just their whole ethics about looking after each other, which is really great to see.
Thank you. That was a really fascinating review of some really important papers. Just coming back to the rudeness question, I think it's really important to acknowledge that we're all human. We all get grumpy and hungry and angry and need a wee or whatever, and that we should all, I think it's really important to distinguish between systemic rudeness and incivility and being human and being forgiving of each other.
Yes.
And also to perhaps learn ways of identifying, to communicating when we're in a bad mood, so that people can see that it's the problem is with us and not with them, because of course a lot of the problems with rudeness is around people internalising what they're being communicated to.
I think it's worth mentioning almost the antidote or the opposite of incivility is kindness, and there are proactive things you can do kindness-wise. And you know, an example would be when everyone's tired and stressed and you're getting lots of calls, as the consultant, go and buy a round of coffees for the team, and it's like pushing the reset button, and so on. And so the important thing is for us as individuals to have insight and to be conscious of how we're behaving. And it's worth, when you are involved in the resus or the really stressful situation, afterwards reflect and say, could I have done so? You know, how was my communication during that resus? Could I have done better? It's not just about did we do the ABC okay? It's did we get the communication and what opportunities can I find for kindness and make the kindness go viral? Then the incivility will go away, I reckon.
So a huge thank you to Susie. I can see there are so many more hands in here, and I'm not ignoring you because we could be, I think, spend the entire session talking about this. But I wonder, maybe if you put your comments through on Twitter, Richard will be able to retweet and the discussion can continue.